right, welcome to Module 2, Lesson 1, and we're going to start to now talk about ICD coding. And we're going to start with the overview to give you some background on how it really has progressed. So looking at the history, the WHO, which is the World Health Organization, they really manage ICD codes. And ICD codes really is when you go to the doctor, it tells the insurance company why you were there. You had a cough, bronchitis, asthma, pregnancy. That really is an ICD code. And looking at the WHO becomes a giant presence in every year and every version of every book. So ICD-9, that was used prior to October 2015. And it actually was implemented in 1979. So as you can see, we used it for a really, really long time. When I became a certified coder, I was using ICD-9. ICD-10, that really was introduced in 1993, but we did not get it live until 2015. So as you can see, it took us a really long time to get it out to live, to be able to use it. And in the meantime, other countries were already using it. So before we got there to ICD-10, lots of other countries, we were already behind. And we've been behind in the history of the diagnosis codes for a long time. ICD-10, the final update was actually done in 2019. So there will be no other changes in all the versions for 2010. ICD-11 is estimated to be no sooner than 2022. And they say no sooner because, kind of like what happened in ICD-10, the government pushed it back. So it really was supposed to start in 2014. Government puts a law out that says, no, providers are not ready yet. So they pushed it back another year. And so that is always a factor when determining when ICD-11 is going to come out. The function of ICD is, big one is to evaluate healthcare costs. Millions of patients are seen every single day, doctor's offices, hospitals, ambulance rides, labs. Think of all the healthcare that is out there. They really want to see what the healthcare cost is now for all these conditions, some being acute and some being chronic. They also want to say, if this is the healthcare cost now for diabetes, and we know diabetes cannot really be cured, it can only be managed, what will be the cost will it be 20 years from now? That helps predict rates and insurance rates. It's also important for ICD, we need that to process and receive payment for insurance companies. You go to the doctors, you may have given the doctor a $20 copay that is not going to pay his bills. You want your insurance to process your claims. We have to tell the insurance companies what the ICD code is. And then really track. They're going to track utilization of services. So they're going to run reports. Everything is, goes into the system. We know the world is digital. Reports can be run. Insurance companies can report back. Blue Cross, Blue Shield saw 100,000 patients with diabetes, and they were seen every month, or they were seen twice a year, or maybe some diabetes patients may not get health care at all. And they really then they're going to get sicker, right? If you don't go to the doctors and manage your health care, you're going to get sicker, which again is going to increase your health care costs. So why do we need different versions? Why do we 9, 10, and 11? Eventually there will be 12. But why do we need that? Well, one, advancements to medicine. There are some ICD-9 was back in 1979. I can tell you they did not have a diagnosis code for ADHD. That came into the 80s and 90s. So advancement to medicines, there are diseases that come up every single day. Mortality, that's a factor as well. Morbidity, that is a factor. Research, right? More research. We want to be able to track patients that were hit in car accidents. These again, statistics. Digital, we wanted everything to be digital. And digital is your electronic, claims can be sent, denied, electronic medical records, everything we want to be digital. Now, interesting enough, the decision was made for ICD-11 back in 2007. Well, if you remember correctly, ICD-10 did not come out until 2015. So even before we got 10 going, we knew we were behind. The United States was well behind on medicine and reporting codes and looking at all the diseases as a whole. When you think of morbidity, mortality, you may think they're the same thing. They are not. They are used interchangeably, but they definitely are not the same thing. So morbidity really refers to your health and well-being now. That's your morbidity. When you think of mortality, this is related to your risk of death. And as I mentioned, they're not the same thing. You could be, morbidity doesn't necessarily mean that your ill health is immediate life threatened. Over time, though, it could be. So let's think of something that could be close to death. If you're on stage 5 cancer, you may be close to death. Your age is a factor as well, your risk of death. So that's how they decide between morbidity and mortality. You will notice in the ICD books that there are sections for these because, again, if we know now that the patient is going to die, they're in hospice, they're going to pass away within the next 6 months, it's good to get those statistics to the insurance company because as people pass on, you look at the population as a whole or how many people are passing away due to this illness. That's how they track these type of things. Looking at ICD-10, as we talked about, the WHO is a major factor in this, and it was approved in 1989. And it took us to 2015 to really get it going. So there's always a gap in time. It's translated into 43 languages, and it's used in over 100 countries. So we already know it's 30 plus years old already. And that is what we are currently using right now. The structure of 10 is a little bit different. And you will see as we go through 9, 10, and 11, how the structure kind of changes. So this here is this starts with an S code, which I know because I've done this for a really long time that is an injury code. And it's really the S86 is injury to the muscle, tendon of the lower leg. And then that second part that you see there, the middle part of those 3 digits there, it's really looking at etiology, anatomical site. We already said lower leg, but what part of the lower leg? Is this a sprain, a strain? Is this an injury, Achilles tendon? You're really going to start to really get into this on exactly, making it more specific. And the D is that extension. So is this the first encounter? Is this the very first time we saw this patient? Is this follow-up care? Patient is home, now they're getting physical therapy, so our D would be on there. Or is this Swakella? And we're going to really get into all this. But this is kind of what the structure of a coding and that what goes into that to pick a code to the insurance company. ICD-11, so kind of like systems, and you think of respiratory, immune system, they break it into chapters of the book. And the book is fairly large, and right now we're working on 10. This is 11. So they added immune health chapter, blood and blood organs chapter, sexual health chapter, sleep and wake disorders, and really traditional medicine. So there might have been things in the mental illness chapter that really might be related to sleep and wake. Traditional medicine is now they're starting people who don't have, like they are doing an au natural way of medicine, homeopathic, those type of things. They're starting to track that now because that does impact healthcare costs. More people are going with acupuncture as a way to get away from pain medication and opiates and things like that. So that is stuff that is worth tracking to the insurance companies and, the whole 9 yards as far as the world. And again, Asia's comparing their health compared to the United States when they really look at it. Now, interesting enough is ICD-11 has 55,000 codes compared to the 14,000, a little over 14,000 we saw in ICD-10. So the book got bigger. There is more codes, more specific codes. Now, there's 31 countries were involved in testing for ICD-11, and about 1,673 participants taking part in all these code assignments. So it's not just about the United States. In Asia, in Japan, Canada, everybody's reporting all these different conditions that they have. Doctors all over the world are getting this together and saying, no, this code actually belongs in the brain section, not in the nervous section, and vice versa. And they're moving them around to how things have changed to put them where they need to be. Looking at ICD-11 in the coding scheme, it's going to look a little bit different than 10. And really the letter in 10 is the first letter. So it would be A 10.9 would look like an ICD-10 code versus ICD-11 is going to look like 5A 10. So you see that letter is in that second spot now. So that really is a big, when we're going through these presentations and looking at all the different codes, this is going to be the thing. When we're looking at 10s and 11, this is really what we're going to look at. The first character of the code, always relates to the chapter of the book. And it may be a number or a letter, but the first beginning 10 chapters are all numbers, that very first character. In order to describe a causal relationship between conditions in a code title, we refer to as due to. Asthma due to allergies. It could be asthma due to environmental reasons. Say there was a lot of smoke or something else had happened, places with a lot of smog. In order to indicate the concurrence of two conditions in a code title, preferred really is associated with heart disease associated with hypertension. The codes of ICD-11 are alphanumeric and cover the range from 1A, 00.00, all the way down to ZZ9Z.ZZ. So a code that starts with an X is really going to be an extension code, and we're going to look into that. The inclusions are force number, the third character position, so prevent spelling things. So ICD-10 had an O, and a lot of people misrepresented that as a 0. And so there was a lot of coding mistakes based on that O and 0. The other one that went with that too is like 1 and I. People got those missed all the time, and it really caused all these errors in that. So looking at some words when we start to break down ICD-11 is STEM code. So STEM codes are being used alone. They say one thing. They don't really need any other codes. They're found in the tabular list of the ICD-11 for mortality and morbidity statistics. STEM codes may be entries or groups of high relevance. So some conditions kind of go together. We have multiple STEM codes and other ones do not. Extension codes are designed to standardize the way additional information is added to the STEM code. So think of your STEM code as your root word, and maybe an extension code would be your suffix. It's going to add something else to the condition. That way we don't have multiple STEM codes. Extension codes are never used without a STEM code. So you cannot use an extension code by itself. It has to be with another code first as part of cluster coding. Cluster coding refers to conventional use, forward or slash, to show more than one code used together. And again, there's going to be medical conditions where one is related to the other. Somebody with diabetes has an ulcer, so the ulcer is the first diagnosis code due to diabetes type 1. That would be an example of codes that are together that really are specific on the patient. Post-coordination refers to linking through cluster coding. So multiple codes, they're really going to fully describe what's documented in the medical record and what's going on. Patient could have that ulcer state. You're going to tell what stage it's in, stage 1, and it's located where? In the left leg. Okay, those are codes that's really, really specific, and it's putting everything together so there's a full picture to the story. An idea of what a cluster code might look like. Look, a simple diagnosis is, talked about ulcer, right? Duodenal ulcer with acute hemorrhage. Well, the cluster code on that is going to be DA63.Z and then ME24.90. Well, the condition we know is the ulcer. We don't know what stage it is, so it's unspecified. Now, we also know that with the ulcer, they have acute hemorrhage. So that's really considered a manifestation. So we have to add another code with it. That's when we're going to get the ME24.90, which is acute gastrointestinal bleeding, not elsewhere classified. And we're really going to get into this as this class and this course goes along and the lessons, but this would be an example of a cluster code and why we would need to use more than one code to tell the whole picture of what's going on with that visit. Looking at ICD-11, currently there is no manual, there is no book. ICD-9 versus ICD-10 all have manuals and books. Currently there is not one. You cannot go out and purchase an ICD-11 manual. They do have some great information, and in the toolbox that I created for you, I have the first 10 chapters of ICD-11. This is a great online tool that the WHO actually puts out there for people and people in healthcare, and I honestly love it. Like tuberculosis, you put it there, and it's going to bring you, as you can see, to all the different manifestations that go with that. And what system? Is it in the respiratory system or is it in the nervous system? You can see how all these systems in your anatomy lessons are really going to come into play. Because you may know what part of the body is, and if you don't know what system it is, then that's going to be a problem in correcting the correct code. So they have this great online. I use it all the time, and we're actually going to use it in this class. So for ICD-11, you do not need to go out and get a book because the information is right here at our fingertips. Post-coordination, we started to talk about this a little bit and this is just what this is going to look like. So as in the top here, you can see malignant neoplasm of the breast, unspecified. Well, we know that most females have two breasts. So is it on the right one or the left one? Or is it both? Both would be bilateral. The word bi means two. Now, it's interesting. They also have unspecified or undetermined, those type of words. I think if you were seeing the patient today at a doctor's office and you reported back you were unspecified or undetermined, how come you don't know which breast it is if you're working? It raises questions. So we try not to use unspecified codes because how could you not know which breast you were given surgery to? You would know because you did it that day. So doctors who use a lot of unspecified codes, a lot of these kick back from the insurance companies, and it also raises other questions of documentation and, fraudulent billing and those type of things. But getting back to this, so you say laterality is right. Now we're also it's asking you specific. Tom, is this the upper, the lower quadrant, which part of the breast? And you can see that when you look at the next, you have all the X codes and really saying, okay, is this the upper part, the lower, right or left? And you can see, I see circled there, is the codes that you're going to use. And this is how you break that down. So this online tool that they have, that the WHO has put out there for us, really helps us really look at codes and more information. Now, if you did not know which breast it was and it wasn't in the medical record, then you can't say right or left. You are going to have to go with an unspecified code because you don't know. And we never say anything that we don't know for sure. If it did not say upper or lower quadrant of the breast, then you'd have to leave that part out as well. You might only be able to go with that first part of the code there because that's all you have for information. And the big thing about medical billing is it's not documented. It didn't happen. Looking at new codes and some of the reasons for different revisions and things like that, I found these codes here to be really interesting. So new codes that ICD-11 offers that we did not get in 10. One big one is problems associated with transferring patients. So if you work in home care, you often have to transfer a patient from one bed to the other bed or different rooms or different parts of the surgery. And then something could happen during that transfer period. So they have a code for that. That was not there in ICD-10. Gender incongruence. This is a giant win when you start to think about folks that are transgender or going through a change or identify if they're born female, identify male. There was never a code for this. Back in 1979, this is not something that was out there that we had a medical definition for and considered a condition. Now it's considered a condition. Gaming disorder. This is a medical condition. Think of all the games teenagers and adults are doing, all that. It wasn't a medical condition. Now it is. It's actually considered a form of addiction, is the gaming disorder, because it impacts their life and the behaviors and, things like that. Post-traumatic stress disorder. This code here was actually in the brain section. Now it's more in the mental health section. So they moved it and gave it a different code and some different wording to really specify post-traumatic stress disorder. Because then it's going to say, is this related to the military or something trauma that happened in a patient's life? It really breaks it down into other possibilities that really tell the whole picture. Just looking at coding over the years, I have lived through 9, 10, and going on to 11. So when I was ICD-9 prior to 2015, it was all numeric. It was super easy, 331.0, Alzheimer's. It was super simple. We moved on to 10. That's when those letters started to pop up there. And now you have G30. Now we're in ICD-11. You really have some letters. You could have one letter. You could have multiple letters in that. It's really changed over time. And that's why when it takes us so long to get from proposing it to actually getting it what we consider live, where doctors are using it. Remember, it took at least 10 years to get ICD-10 even out there because we had to move to electronic medical records. A lot of providers were using paper. We had to make changes in the documentation to be able to use ICD-10. Then you had to upload all the systems. All the insurance companies had to be updated. Everything had to be updated. Now that we're going to 11, it's going to be not quite as hard, but I'm expecting a little pushback because anytime doctors have to make changes, sometimes it adds money out of their pocket, adding systems, adding staff, and that's a money situation. So they do try to push back because they kind of feel if it's not broken, why change it? A crosswalk. So a crosswalk is a wonderful tool. In your toolbox, you do have the crosswalk from ICD-10 to ICD-11. And the reason why is currently we are on ICD-10. So if you were to take a class and certify today, you would be testing in 10. If 2022 you are going to have to test in ICD-11. If it's close to ICD-11, you may have to test in both. So crosswalks are super important because if you didn't know where to start and you already have a patient that you've seen for bronchitis or, enteritis due to the norovirus, let's take that one. So if you already had AO 8.1, you could crosswalk that, and it at least will take you to the 1A23. And then it's going to ask you other questions. That third column is the chapter in the book, and then the next column is definition, kind of how it's broken down. So crosswalks are super important. You will use it frequently in this course because some things that we'll be talking about are in 10s that we need to crosswalk to 11, or vice versa. It's a great tool for you to use and really start to see, okay, this is what it's going to look like, and at least take you to the right chapter. The building blocks of coding, really when we are looking at a medical record, patient went to the emergency room, motor vehicle accident, and now I have this doctor's report on electronic medical records, so it's all typed up, so I don't have to read the writing, which is very helpful. I need to figure out what ICD code I'm going to put on this. So the first thing I need to do is look at the main term and assessment statement of the medical note. I often will read the entire note first and then go back and look at it because sometimes it's not at the beginning, sometimes it's at the end, and that really will help me figure out what the doctor's thinking about. Because sometimes you go to the ER or any doctors and they may think it's one thing, but it turns into something else, or they may think it's something else. They don't really know. So getting in a habit to read the entire document before you even get started is the way to go. So we're going to identify the main terms and then say, okay, motor vehicle accident, we think it is a fracture. So then we're going to go to the alpha index, define the term. So that's your first thing. You always want to start with the alpha index. So besides, I'm going to look for a fracture. And in the very front part there, in the first bunch of pages, there's going to be an index. And I'm looking for the word fracture. And then that is going to take me to a page and codes that it thinks it is. So then I'm going to go take that, and I'm actually going to go to the main terms and the tabular section. And it's going to cross-reference me to go to that. And then it's going to say, see also, or I'm going to notice, is this a fracture of the right arm, the left arm? Is this, and then it's going to break it down again. Is this in the lower extremity? Is this a tibia fracture? What type of fracture is this? Is this an open fracture, a closed fracture? These are things, as you remember we talked about in anatomy, that are really going to come to play. It's like a building blocks. So once we're in that tabular section, we've got that. We're going to review any instructional, code this, don't code this, see if any of those really apply. Is this the first time that we're seeing this patient in the ER for this fracture? Is this follow-up care? Or is this follow-up, from an injury that happened a long time ago? If it's in the ER, it's probably the first time we're seeing this patient. So actually at the end of this, if we were looking right now and say if we were looking, we're going to say this is the initial visit. And that's how we really tell the insurance company, how many times a patient has been seen. That's how they track this stuff. Assign codes to the highest specificity. We talked about that. And you're going to code all elements of the diagnosis in the medical note. So they may be seen for that fracture from the motor vehicle accidents, but also they have a scrape or some glass in their arm. Not only are we going to code the fracture, we're going to go and code that arm scrape that they have there and removing the glass that's in there. It's going to call the foreign body. So that's how we're going to kind of look through that and get the codes. You always work in pencil, so it would be completely normal to kind of jot down a code. Nope. Go back and do some more reviewing as you look at the whole picture. Sometimes you have to go see the doctor and say, hey, you didn't say what arm this fracture was in. And then he's going to say, well, he had x-rays. And that's going to lead you to the x-ray report. And then you're going to go see there if you can figure out what arm. It may take you to another piece in the medical record to connect all the dots before signing the correct code. NEC versus NOS. NEC is not elsewhere classified. And then NOS is not otherwise specified. So the big difference here is NEC, not elsewhere classified. That means the book did not have the specific disease or condition in there. Not otherwise specified means the documentation did not have enough information for you to do that. And a big one here would be, let's say, unspecified glaucoma. It says the doctor said glaucoma, but he did not list what type, and there was no lab work. There was nothing else that went with it. If it's not documented, it didn't happen. So I have to choose an unspecified glaucoma because I'm not sure which one there is. Versus other specified, like say cataracts, means that there's a list of cataracts, but the particular one that patient has is not listed in the book and not that condition. So that's how that kind of gets broken up into different things. These codes here start with letters. So like H26.8, that is a 10 code. And as we talked about, we're going to actually go back and forth because currently the whole world is on 10 and we are moving towards 11. And it's important to know both the codes, they're all coded the same way. So your procedure for finding the right code's all going to be the same, but the codes are just going to look a little bit different, which is why I put that crosswalk in your toolbox. Parentheses. This takes you back to grammar school in English. And looking at punctuation. These will be in your book. So parentheses used to enclose supplement wording that may or may not be documented and does not affect the code selection. So the big word here is does not affect the code selection. Terms in parentheses are often called non-essential modifiers. Means that they kind of mean the same thing, but when you see the other word, it doesn't really impact it. Diabetes is a big one. So in the note, it might say diabetes, diabetic. It might also say menulitis, and it might say sugar. At the end of the day, this patient has diabetes. Now you just need to figure out if it's type 1 or type 2. Hypertension. In the book, it says essential, but maybe your doctor wrote down primary hypertension. This is where your guidance in your book is telling you, you know what, they mean the same thing, just use this code. And whether you were, like I said, whether you were working at a 10 right now or you were currently working on 11, you're still going to get these punctuation. These are all going to say the same. It's going to includes, excludes. All this punctuation and parentheses are all going to kind of come into play here. Another form of punctuation you probably used in high school. So enclose synonyms, alternative wording, or explanatory phrases in the tabular list and identify manifestation codes of alpha index. So the index for your alpha, you're going to look under disease, Alzheimer's. And then it's going to say G30.9. But it's also going to put into brackets FO280. So you're going to write down the FO280 and you're going to go there and you're going to see, is this related to my patient's condition? And you may need to read more than one document. It may not be today's office visit. You may have to look at their medical history. You may have to go back and say, well, they were seen 3 months ago for a related illness. Is this the same? Maybe look at some lab reports, an MRI report. These are all factors that might go there. In the tabular list, you might see brackets being used as rubella. So you have the B06, rubella, and they're also putting brackets here that says, German measles. You kind of put that together and say, all right, these here are manifestations. They're related. This is the code that you use. So you can see between index and tabular that these codes here in the brackets were used differently. One was for codes to take you to a different code that might be applicable. Or tabular is saying rubella, German measles, they're all kind of the same thing. Colons. So colons are used in the tabular after an incomplete term, which needs one or more modifiers following the colon to make the code complete. Remember that every ICD code, 10, 11, 9, they tell the story of what's going on with the patient. And some conditions are related and some are not related. A colon is used in both includes and exclude notes, in which the words that precede the colon are not considered complete terms and must be, again, appended by other modifiers and other codes. So looking at this one here, G7 3.7, you have myopathy in a disease classified elsewhere. Well, they're telling you excludes 1 colon. So this G7 3.7, if the myopathy is in the rheumatoid or the lupus, you know what I mean? These here excluded. These are excluded. You got to go to these other codes. You can't use G7 3.9. They're telling you, and again, you're going to get that information out of your operative report. Why was the patient here today? Oh, they had myopathy. Is it related to rheumatoid arthritis? Well, we're not going to use G7 3.9. We're going to go check out MO M05.32. And that's going to lead us somewhere else and say, okay, this is when we do because our patient does have rheumatoid arthritis. They are factors. They are manifestations. These are related conditions. Combination code. Only utilize a combination code when the code fully describes the conditions documented. So if it's not in your documentation, it did not happen. Or when 10 or 11, it directs their use. And again, as we've noticed in the examples before, your book, your manual, your online guidance, that's what's going to take you to use that other code. You're just not going to open your book and decide to use it. It's almost like following a maze and being a private detective. You have to figure out which code needs to be used next. So a combination code is a single code used to describe 2 diagnoses, a diagnosis with an associated secondary process, considered a manifestation, or a diagnosis with an associated complication. Guidelines state that when multiple codes should not be used when you clearly have a combination code. A good one for this, an example would be, I see denials all the time for carpal tunnel. Say a patient has carpal tunnel in both the right and left wrist. There are codes for right, left, or bilateral. So a rookie mistake would be you would put the right code, the left code, and not put the bilateral code. The insurance company actually denies that out and says, hey, you used 2 codes when you could have just used 1 combination code to say the entire phrase that really is both right and left. So that's one example of what comes out. You can't use multiple codes when you can have 1. When you suspect that a combination code may be applicable, but supporting documentation is lacking a query, you're going to query the physician. When they say query the physician, you're going to go ask your doctor, Dr. Smith, you had a car accident, you had a fracture, but you did not say if that's right arm or left arm. And he may say right. And then you're going to say, can you please put that in the medical records? Or he may say, I'm not sure. I can't remember. That was 12 patients ago in the middle of the night. Can you please go look at the x-ray report? And then you don't need him to add it to the medical record because the x-ray report is in the medical record. So you can use that as a basis of getting the correct code. So query your physician is you asking questions to your doctor to get more information, to kind of connect the dots to figure out what this patient's diagnosis is. Looking at ICD-11, this is kind of what it looks like. So you have all the chapters of the book. Now, the chapters in 11 look different from the chapters in 10. So these are all broken up. You can see that you have the new chapters, conditions related to sexual health. That was not a chapter in 10 nor 9. So every time we have a new version, we're going to have new chapters. They're all going to look a little bit different. But in the end, you see sleep-wake disorders as well as chapter 7. There's no particular order. Whatever order is that they had, this is what we have to go with. Sometimes they are resembling. I can tell you number 1 for ICD-10, infection and parasitic diseases. That was chapter number 1 for ICD-10. So it's the same for 11. But I can tell you that sleep-wake disorders was not there. So chapter 7 was not sleep-wake disorders in chapter 10. You can see how this is broken down. So if we chose chapter 1, it is broken down to different diseases. So you have your sexually transmitted. This is where you're going to find that in there as well. You have bacterial diseases. This is viral diseases. What type of disease? If you are working in infectious disease specialty, and this is something that you are working with, you're going to know real quickly and learn real quickly which diseases are bacterial, which ones are viral, which ones are sexual. You're going to find that out really, really quickly. You will either make yourself a cheat sheet, or you'll just, if you remember things really well, it'll be just repetition. Working in the same specialty for, at least a year for each one, if not longer, will really make you an expert at that. So you will do less book work because you already have that. Breaking it down, you can see them break it down. We started just plain old chapter 1, infectious parasitic diseases. Then we chose the gastro infection origin. Then I went with bacterial intestinal, and that takes me to the chlora. You have others that go with that here, all the different, like I said, we're talking infection, typhoid fever, different things like that. And you start to see where you have the number and the letter and then breaking that down. So say I chose 1A00 for chlora. You say, okay, there I have that disease right there. It has the inclusion, so if you saw that this syndrome was in the medical record instead of the chlora, you would know that that includes that. Then you have the post-coordination. This is where you get into the clusters. They tell the whole story. Remember that. They're saying, what's the infective agent, right? What type of infection is this? And there's different ones. There's different strands. So if you're working in infectious disease, you have different strands of diseases. Even viruses, a flu virus, different strands are out there. There are new strands that happen every day. Breaking this down some more, so I pulled this out of your chapter 1 out of your ICD-11. You can see how not only does it tell you have the code and what the disease is, but it nicely has a description. So if you were new into the field, you would need to have a little cheat sheet, and it has it right in the book of what you were looking at. This is what a syndrome is. This is what it's characterized by. If you weren't sure, you're going to look at some of the signs and symptoms that go with that. You can see where it has exclusions, other specified congenital hypothyroidism. You can see where it has different things that go with this to help guide you. You do not know. To test and to certify, you do need to know the entire book and have a very big variety. But to work in a specialty, one specialty, you don't. I worked OBGYN for 5 years, and I knew just that chapter in and out of my head, and really everything that went with it. And then when I wanted to learn something else, I just switched to a new chapter. So you do not need to know every single disease in the book to be able to do this and assign a code. You do need to read an understanding and read the medical documentation that the provider gives us. Instructional notes. These are various forms of instructions. It's in 10 and 11, code first, use additional code, or they cross-reference. We talked about this. We've already seen some with includes. It's important to remember that a list of inclusion terms is not exhaustive and may be more than that. But a lot of times it will help you if your documentation in the doctor's record does not exactly fit what is in the medical book. Doctors have been doing this, for a long time. So diabetes, going back to diabetes, they might just say that the patient's meningitis. They might just write DM. They might not say type 1, type 2. You really got to dig and see what that includes and take it to the next step. Includes examples that we found that would go with this. So this is a gastric ulcer. Includes an acute phase, the peptic phase. So they're saying that these three here are included into the K25. And that goes with that. So you have that already there for you, where your medical documentation could have any one of those three ulcers, but at the end of the day, it's still going to be K25. So here you say where they are really guiding you and telling you to look further. You can't just have just one code. So this is a hypertensive heart and chronic kidney disease with heart failure and stage 1 through 4. Okay, so CKD is chronic kidney disease. So when you're looking this up in the book, it is telling you use additional codes, what type of heart failure. And it's kind of guiding you because it's saying I-50. You are going to write down this I-13.0 in pencil and get that code. And then you know what? You're going to go and say, okay, I know what type of heart disease and heart failure. I'm going to go to the I-50. It also says additional code, what stage? What stage is the CKD? Then you're going to use an N code. So you're going to go look there. After you look in your documentation, what stage are we talking about with this patient? Maybe it's not in Dr. Smith's note for today. I may have to go back to the note from the doctor who sent them here. I have to look a little further. You're a private eye. You got to connect all the dots to put the codes that tell the complete picture to the insurance company on what's going on. You see, like I said, you really see that heart failure. Those are big ones right there. If you're working in that field, you are using multiple codes. Yearly updates. It's important to know, and we talked about this at the very beginning under disclaimers, is that there are changes that happen on an annual basis. There are diseases that are come out that weren't there before. Zika virus is one of them. That just came out a couple years ago. That was not there when they first came out with ICD-10. It's something that's popped up in the last couple of years. And then as they learn more about it, then they really start to specify it more. When it comes to Zika virus, you could have got that today. I'm a pregnant mom. I have Zika virus myself. But if you're pregnant and your baby's born, now the baby has it. So it's congenital. So that's a different code. So they really start to get these updates. It's important to know that healthcare changes constantly. More codes, more diseases. It's something that you cannot just learn today and then not follow through on. You always are constantly reading and making sure your yearly updates you know. In this case here, Chapter 1, if you're working in this specialty of Chapter 1, this would be your update. No change under that, no change. Oh yeah, Zika virus. All right, baby's born. I might use this here code instead of this one to put the difference between someone who just got bit and got Zika virus today versus a baby that was born and kind of developed that when they were born. Review question. So ICD-10 was originally introduced in 1993 by A, CMS, B, MHI, C, the BBC, and D, the WHO. So the answer to that is going to be the WHO, D.